Hello, my name is Donald Terrace, and I'll be presenting my scholarly project implementing an antibiotic stewardship program in urgent care. My committee members uh, were Dr. Hoffner, Dr. Condon, and Mr. Abbas, my community member. The purpose of this project was to reduce inappropriate antibiotic prescriptions for upper respiratory infections, commonly referred to as URIs, by implementing an antibiotic stewardship program, or ASP, in an urgent care setting. URIs are among the most frequent reasons patients visit urgent care, and yet most of these infections are viral. Despite this, antibiotics are often prescribed unnecessarily. According to Fleming, Dutra, and colleagues, in 2016, around 40% of outpatient antibiotic prescriptions are not appropriate. In the urgent care specifically, the problem is even more pronounced. Studies show that up to 46% of antibiotic prescriptions in these settings are unnecessary, making urgent care one of the highest contributors to outpatient antibiotic misuse. This contributes directly to antibiotic resistance, a public health crisis that is responsible for over 2.8 million infections and 35,000 deaths each year in the United States. One of the major challenges we face is the urgent care environment itself. Providers are often have limited amounts of time with patients. There's a strong pressure to meet patient expectations, many of whom believe antibiotics are necessary for common conditions like a cold or a viral flu. My project seeks to address these issues by providing both provider training and patient education, with the goal of improving prescribing practices and reducing resistance. The literature strongly supports the need for antibiotic stewardship programs in urgent care settings. For this project, I reviewed 14 primary research articles published between 2014 and 2024. These studies were identified using a structured strategy through Ovid and Medline databases, focusing on keywords such as antibiotic stewardship, urgent care, and CDC guidelines. The evidence consistently shows that inappropriate antibiotic prescribing is common in urgent care. For instance, Blanco et al. In 2022 highlighted persistent overprescribing, particularly for upper respiratory infections. Several barriers to appropriate prescribing were identified in the literature. Desai et al. And Manning et al. Noted that patient demand was high, there was a limited consult time, and a lack of standardized clinical guidelines all influence provider behaviors. Recommended interventions include provider training, delayed prescribing, and the use of CDC-aligned decision support tools, all of which have shown to improve clinical practice. Importantly, Patel et al. In 2023 concluded that comprehensive ASPs that combined both provider education with decision support tools are the most effective in reducing inappropriate antibiotic use in urgent care. These findings directly shape the design of my quality improvement project. This project was guided by Rossworm and Larrabee's model for change in evidence-based practice. This provided a structured 6-step process for implementing meaningful clinical change. The model began with identifying a problem, in this case, the overprescribing of antibiotics for URIs in the urgent care. Next, I linked this clinical issue to evidence-based interventions by conducting a literature review and identifying strategies like provider education, CDC guideline integration, and delayed prescribing methods. From there, I designed the antibiotic stewardship program and implemented it through pre- and post-intervention framework using training and patient education. Importantly, The model also emphasizes evaluation and sustainability. After implementation, I measured prescribing behavior changes and planned for ongoing provider engagement and protocol reinforcement. Overall, the model helped ensure that every stage of the product was rooted in best practice, supported by evidence, and capable of creating sustainable improvements in clinical care. This project, utilized a quantitative exploratory design as part of a quality improvement initiative. The goal was to assess whether implementing an antibiotic stewardship program could reduce inappropriate prescribing for upper respiratory infections in the urgent care setting. The intervention involved three main components: provider training on CDC prescribing guidelines, the introduction of delayed prescribing options, and patient education materials to reduce demand for antibiotic. These components were selected based on evidence from the literature that supports their effectiveness in improving prescribing practices. Data collection was retrospective, using electronic medical records from adult patients aged 18 to 89 who were diagnosed with flu, bronchitis, or pharyngitis. The design compared two groups: 86 patient records from before the intervention to 89 after, for a total sample size of 175. By choosing this approach, the project was able to evaluate changes in provider behavior over time while maintaining the clinical setting's integrity. The structure supported real-world application and gave meaningful insights into how educational and systemic interventions might influence urgent care prescribing practices. These bar charts show both the gender and diagnosis in the pre and post intervention group. In the month before the intervention, the majority of patients were female, with 54 women and 32 men being seen for qualifying respiratory infections. In contrast, the month following the intervention saw a significant shift, with 65 male patients and 24 female patients. This change was not intentional or related to the intervention itself, but reflects normal variation in patient volumes and demographics during the two review periods. However, it is important to consider this shift when evaluating overall outcomes. The second chart shows the distribution of diagnosis by ICD-10 codes for the month of September and October. The most common diagnosis in both months was JO2.9, which refers to acute pharyngitis unspecified. This accounts for the largest number of visits in both periods, with slightly more in September than in October. The second most frequent diagnosis was J20.9, which is acute bronchitis unspecified, with nearly equal distribution across both months. Only a few patients were diagnosed with J10.1 or J10.2, which are codes for influenza with respiratory symptoms. These cases were minimal and consistent with seasonal variation. This distribution confirms that the study remained focused on URIs most associated with inappropriate antibiotic use. For this project, I used a z-test for the difference of two proportions to compare antibiotic prescribing rates before and after the intervention. This test was selected to determine whether the change in prescribing behavior was statistically meaningful. A power analysis was completed, and the sample size of 175 was determined to be sufficient to detect a medium-size effect. The confidence level was set at 95%. The calculated z-score was 1.0836 with a p-value of 0.8607. Because the p-value was greater than the 0.05, the results were not statistically significant. This means that while changes in provider behavior were changed, they could not be attributed solely to the intervention based on the data collected more time or additional reinforcement may be needed to produce a measurable impact. The results of this project, based on the 175 patient records, 86 pre-intervention, 89 post-intervention. The goal was to determine whether the antibiotic stewardship program had an effect on prescribing behavior for URIs. In the pre-intervention group, 32.6% of patients received antibiotics. In the post-intervention group, the rate was slightly increased to 40.4%. A z-test for the difference of the two proportions was conducted. The calculated z-score was 1.0836 with a p-value of 0.8607. Since the p-value was greater than the 0.05, the results were not statistically significant. This means that no meaningful difference in prescribing behavior before and after the intervention during the 1 month study period. However, anecdotally, there was an observed increase in patient education and provider awareness, which may lead to longer-term change. While this project did indeed provide valuable insights, several limitations have impacted the outcomes. First, the project was limited to a single urgent care in northwestern Ohio, which affects the generalizability of the findings. The results may not reflect what would occur in other settings with different patient populations or organizational cultures. Second, the sample size, while adequate for the power analysis, was relatively small, with only 175 records being reviewed over 2 months. The time frame may not have been long enough to capture meaningful changes in provider behavior. Another limitation was the short duration. Behavioral changes, especially in prescribing habits, often take time. A longer implementation and follow-up period may have yielded different results. In addition, external factors like provider workload, time constraints, patient pressure to receive antibiotics may have continued to influence prescriber decisions despite the intervention. Lastly, the project relied on retrospective chart review, which depends on accurate and consistent documentation in the electronic medical record. These limitations should be considered when interpreting the results and planning for future quality improvement studies. The findings of this project revealed that although there was a slight increase in antibiotic prescribing after the intervention, the change was not statistically significant. This result may seem unexpected, but it aligns with literature that suggests that changes in provider behavior, especially relating to prescribing, often take longer to appear. Even with education and tools in place, long-standing habits and external pressures such as patient expectations, time limitations continue to influence decision. That said, the intervention did promote increased provider awareness and patient education, which are critical first steps in building a culture of antibiotic stewardship. Informal feedback from providers indicated greater mindfulness around prescribing, and patients were more frequently engaged in conversations about viral versus bacterial infections. These early changes suggest that while the quantitative results were not statistically significant in the short term, the foundation was laid for long-term impact. Moving forward, reinforcement through ongoing training, expanded education, and EMR-based decision support tools may enhance adoption and sustainability of stewardship practices. Antibiotic stewardship programs need to be thoughtfully tailored to the urgent care environment. Unlike patient or specialty settings, urgent care operates under time pressure with high patient turnover and limited diagnostic resources. This creates unique challenges that require practical, efficient solutions to improve antibiotic prescribing. To achieve lasting impact, provider engagement must go beyond a one-time training. Continued education, reinforcement of CDC guidelines, and leadership support are essential. Implementing policy changes and embedding clinical decision tools in the electronic medical record can help providers make evidence-based choices quickly and consistently. These efforts also support national public health priorities. The Center for Disease Control and Prevention emphasize the importance of reducing inappropriate antibiotic use to combat rising antibiotic resistance. By aligning urgent care practices with these national goals, we can enhance patient safety and improve outcomes at both the local and systemic level. And ultimately, a well-executed stewardship program can reduce unnecessary prescriptions, lower the risk of antibiotic-related complications, and protect the long-term effectiveness of these vital medications. This project set out to reduce inappropriate antibiotic prescribing for upper respiratory infections in an urgent care setting through provider education and patient intervention. While the results did not show a statistically significant reduction, the project still laid an important foundation for long-term changes in clinical practice. More importantly, this experience has been incredibly meaningful to me personally and professionally. Working through the design, implementation, and evaluation of this project deepened my understanding of how real-world change happens in healthcare, not instantly, but through consistent effort, collaboration, and reflection. It also gave me a clear picture of the barriers providers face daily and helped me grow as a clinician and a leader. I learned the importance of data, but also the value of relationships, communication, and persistence when trying to improve outcomes. The DNP program as a whole has challenged me to think critically, advocate for evidence-based care, and remain committed to quality improvement even when the results are gradual. I now feel more prepared to lead change, support my colleagues, and contribute to a healthcare system that prioritizes safe, effective, and responsible care. Going forward, I plan to advocate for stewardship, expand this initiative across other clinics, and keep refining the process so the impact is both measurable and meaningful. If there are any questions or comments, please feel free to contact me at dterrace1@live.maryville.edu. Thank you for your time. And the references.